I would like to welcome to the conference this morning our keynote speaker, Dr. James Evans. Dr. Evans has just recently been elected to the position of Medical Co-Chair of the New South Wales Agency for Clinical Innovation Stroke Network. Dr. Evans is a neurologist with subspecialty interest in stroke. He completed his neurology training on the Central Coast and in Sydney in 2016. He also completed 2 stroke-specific fellowships, one at Gosford Hospital and a year at the well-regarded Calgary Stroke Program in Canada. He has a specific interest in neurovascular imaging and stroke system implementation. James is the head of stroke services at Gosford Hospital on the Central Coast of New South Wales, and he's also the Deputy Director of the New South Wales TeleStroke service. He is also a Conjoint Fellow, School of Medicine and Public Health at Newcastle University. James has a keen interest in supporting service delivery improvements across the whole acute and subacute stroke patient journey. He has been actively involved in quality improvements for hyperacute stroke care both locally and regionally. James is passionate about real-time data analytics that allows a data-driven understanding of care and an active approach towards system improvement. This is James' first appearance as the co-chair of the ACI Stroke Network, and in his presentation today will address Stroke 2021 and beyond. So please join me in welcoming Dr. Evans.
So thank you for that kind introduction. As you heard, I have a number of hats today. I'm really coming to you with my TeleStroke service hat on because a lot's been happening with the TeleStroke service, and it's getting very exciting, and we're really building, and I would just like to sort of take you through some of the work we're doing and show you a bit of what a TeleStroke consult is like. So the talk in general was going to be a bit of an update where we're up to, where TeleStroke fits into that, and then a bit of reflection on the last 12 months or so since the beginning of the TeleStroke official journey. And I'll show a clinical case, and then we will talk about, where to from here in terms of TeleStroke and beyond. So as you're all very well aware, stroke is a really significant problem in Australia. It's a major cause of disability, and importantly, a large percentage of stroke survivors are of working age. You all have a very good understanding, no doubt, of the way a stroke occurs. There is death of brain early, and an expanding core, which means that if we're able to unblock the blockage, then we can salvage the so-called penumbra if we can open the vessel in time. As well aware, there are treatment options for stroke. This is new and hasn't changed recently, with thrombolysis, with alteplase, and endovascular clot retrieval. In 2015, there was a number of clinical trials which demonstrated the benefit of clot retrieval, and I don't think this is something I need to go over today. In 2017, there was further trials which suggested that expanding the time window for delivering clot retrieval, something that was also significantly beneficial. So therefore, what therefore is the problem? And basically, the problem that we face is the size of our state and country, really. On top of that, regional Australians are far more likely to experience a stroke. They're also more likely to have more significant disability as a result of their stroke. And this is in part due to the systems of care. The stroke specialists are located in metro areas, and so people in more rural areas just don't get the access to the same level of care that their metro counterparts do. So here is the role for TeleStroke. It's not a new concept, and it has been utilised throughout the world, with the Victorians having a great system already well and truly set up. And basically, it just brings us to the patient. But for a long time, there was no funding in this state. So some time ago now, 2017, we commenced a pilot program starting at Coffs and Port Macquarie. Basically, it was myself and one other neurologist who just put up flyers saying, call us if you've got a stroke patient. And we got CT perfusion set up there on the computers, and with some really key local support, we were able to start taking scans or taking calls and making decisions on patients' care. We combined our data with the John Hunter TeleStroke network as well, and because they were providing care within their own LHD, but we were able to demonstrate that it's possible to provide care across LHD boundaries, and the combination of the data from their project and our project combined showed that there was definitely benefit and it was feasible to do. So in 2019, there was a $21 million election promise to build a TeleStroke service over 3 years. It was a little bit impacted by COVID as we were unable to get out to the sites, but we're kind of back on track and looking to deliver those 23 regional sites by the end of that 3 years. And the good thing about it is it's really just leveraging existing technology that's there. We use Skype for Business for our teleconferencing needs. We've got the perfusion software Rapid there, and we've also got a documentation program and the EIR, which is a standing imaging viewing platform that we use. None of this is particularly fancy or new. Here is the model of care, which I'm just going to skip over because I think this next slide shows it a bit better. Basically, a spoke hospital, somewhere, say, for example, Coffs Harbour, would call us. They would notify us that there's a patient who has the symptoms of a stroke. We would confirm that that sounds like a good case to take to the scanner, and they would take the patient to the scanner. We would then join up with them after reviewing the images as they come to us in the moment, and we then assess the patient. Now there is 6 and growing neurologists on the service, and we do it all via teleconference, as you would understand, and then we make decisions on the patient's care with the local teams enacting those treatment plans. And if the patient needs to be transferred, then we arrange the transfer to the endovascular centre, and the patient goes there to get therapy. I'm not going to go too much into detail because I don't think that's really what good use of the time, but this is a really important part of our service. So many patients come in with all different sorts of presentations, and we really want to make sure we're being called about the right patients that we can provide the most benefit. And this is a screening tool, which is an online web form that they basically fill out, and it tells them, based on the patient's premorbid function, based on the timing of the onset of the symptoms, the severity of the clinical deficit, whether or not there's going to be benefit in getting us involved. And so yeah, that's the first step for them to perform. We've also used that same platform to create documentation. So we have a tick box styled, again, web form. You can see there's a bunch of tabs there next to clinical history, exam, investigations management, that we just basically go down, and it produces a standardized note, much like what you would see on the right. So that way we make sure that our documentation is very solid. It is ticking all the boxes of important things that we need to cover and giving us prompts if in the moment, something could be forgotten. Because we're using this web-based form, we can, or platform really, we then get the data. So this is an oldish slide. We're obviously well past September, but you can then look at a site and really break down the metrics of when did they call you for each patient, how long did it take them to get to the CT scanner after that, and it allows you to really dig down into local process issues. Ideally, those trials all showed that the quicker you can deliver the care to these patients, the better the outcomes are going to be. And so the challenge really is improving the processes such that every patient gets a really good go. And looking through these sorts of bits of data is incredibly useful, because sometimes it's an unavoidable problem, but sometimes someone's missed something, or the processes has not been followed, and it's a really good opportunity to draw everyone back to the importance of following the protocols, because when the protocols are followed, we do see some really great times. You can see in the door to alert there, if that's showing up big enough, you can see sometimes they're calling us under 10 minutes. So the patient's just arrived, they're calling us, we're in on the case, we're assessing them, and we're treating them quickly, which is going to give the better outcomes. This is the imaging platform. It's a pretty standard imaging platform, to be honest, but it does give us workstation capabilities. It allows us to really manipulate the imaging. And the most important thing about it is it sends to us before it sends to the local PACS systems. So it's sent across the internet before they can even see it locally. That's how fast it's coming to us. And that's really critical because we need to make fast decisions. And so getting the scans sent to us straight away, we're looking at them before the patient's even off the scanner, and we're working towards making decisions. This is the tech that we use. That's one of the workstations on wheels to the right there, and you can see that there's a camera, there's a phone for private conversations, there's also a speaker there that allows us to broadcast to the whole room if we wanted to. We definitely see discussion with patient and family as a really important part of stroke, hyperacute stroke management. And it allows us to discuss things like consent. We've got information sheets that we can provide to the patients about the therapies that we're recommending. And, it also allows us to essentially be in the room on the computer there for the process of giving the drug and, working through, because sometimes, these drugs are given infrequently, and have someone who's seen it done hundreds of times is extraordinarily valuable. This is an example of Coffs Harbour. It's a slightly old slide. Before 2016, there's essentially no thrombolysis given, which, obviously TPA was proven to be beneficial in 1995. So this is an example of what it's like at many of these sites. In 2017, we started doing the pilot, and whilst we were getting some okay times, we were certainly getting some very slow times. And you can see that once we got the proper funding and we got an ability to put together a package for these sites, which included a structured education program, we've been able to focus the door-to-needle time. So each one of these dots is a patient that got treated, such that we're getting more patients treated, and the overall times has dropped by half an hour in terms of the median treatment time. So this is only going to improve as we really bed the system down over the next few years. So it's time for a case. We have a female here who, I'll just sort of step through it how it would fly for a usual TeleStroke case. So this is a patient that has no significant past medical history or regular medications, school teacher, and she awoke with symptoms and was last seen well at 10 p.m. She had a bit of a headache, and it was noted that she had aphasia, as in she couldn't talk. She tried to call her sister on the phone and was unable to talk properly, who called an ambulance, and she presented to the hospital at 7 a.m. Her vitals were stable, and her findings were that she had an aphasia and a right-sided sensory and visual inattention. She wasn't able to tell that there were things happening in both visual fields, or she wasn't able to detect sensation on both sides at once. Now, they were very quick, and they contacted us 6 minutes into her arrival, which is fantastic. And this is her perfusion scan as they would come through. So what we're looking at here is anything that is in red is predicted to die, no matter what we do. And anything is green is salvageable. The numbers down the bottom tell you a more quantitative view of that. So the red adds up to 11 mils, and the mismatch, the green, is 50 mils. So that's how much brain is potentially salvageable if we can open up the blood vessel in time. and this is a patient that coughs. And so as you can see, there's an interesting, decent sized perfusion lesion there. The next step really is to focus on the non-contrast CT brain and look in that same area. Basically what we're doing is we're trying to compare the affected area with the other side, essentially, to see whether there's any early ischemic changes. You can, on this slide mainly, you can see that in that region where the perfusion lesion is, sorry, I don't have a pointer, there does look like some subtle asymmetry to the other side, but overall it looks very good. It looks like this brain is definitely salvageable, and that's in keeping with the perfusion scan as well. This is the CT angiogram. Again, it all comes through very quickly, and I'll direct your eyes, again, unfortunately I don't have a pointer, but I'll direct your eyes to the right that it is going to curl around the corner. And if you just keep following that vessel as it's now trending down, it's facing down now, it's going down further, and you see it's just not progressing beyond that point, and now it's disappeared. If I go back, you can see it's just looking like a stump. So this is what an occlusion looks like. So to summarize, we've got a independent. She's a teacher. She's a wake-up stroke, so she is about 9 hours since she was last seen normal. She's got a significant deficit, including language and neglect, which is a disabling deficit as well. And her imaging shows a favourable profile without any significant changes on her non-contrast scan. She has salvageable brain on the perfusion scan, and she's got what we would define as an M2 occlusion. So obviously this is a patient we really want to treat, yeah? Is she even eligible for any of the reperfusion therapies? And I'll just go back because I'm spoiling it. But the reason that I asked that question is technically she's outside the 4.5 hour window for thrombolysis, so that should be contraindicated. And also those trials that I showed you, they were all talking about more proximal lesions. So they were talking about occlusions in say the big major vessel before it turned around the corner on the slides of the CT angiogram that I showed before. So she's got a smaller vessel that's occluded, and that again is not in keeping with the trials. So this is the sort of case that I think is excellent to show, because if you're not an expert in stroke, then you're not aware of some smaller data, some smaller trials that are encouraging for patients in these sorts of groups. So there is some data to say that M2 occlusions are safe to perform clot retrieval in, although that's outside of the major trials. And also there is data that in certain circumstances, especially in a highly favourable profile, that giving thrombolysis is a safe and appropriate thing to do in wake-up strokes. So because of that, she was given treatment, and she was accepted to John Hunter Hospital for clot retrieval. And unfortunately, her daughter needle time was a little slower than what we would have liked, especially after such an early call. With these cases that are a bit fringe, you really need to make sure that you are assessing the patient adequately. And because she is on the borderline of being appropriate for some of these therapies, it was important to clarify that and explain fully that this is not a straightforward slam dunk scenario. And many even neurologists around the state might say that this is not indicated to treat this patient. So in a case like that, you really need to make sure that everyone's aware that the treatment that we're providing in this instance is the right thing to do, and that we've considered all the options and explained that we're basing this decision off a less solid basis for the data. Anyway, so the patient got the drug, and by the time they arrived at John Hunter Hospital, they had improved. And this is a repeat perfusion scan. You can see in the bottom left of the screen, those numbers have gone from 11 and 50 to now 0 and 4. And it's essentially a normal CT perfusion. So obviously ECR or clot retrieval was not required. This is her follow-up MRI. You rarely walk away from these things without some stroke, and you can see anything that looks a little bit bright on that right side of screen, left side of the brain is an area of stroke. So she's had a smaller bit of stroke there in the insular cortex, and a few other little bits of bright white dots around the place. All of those bits are small areas of stroke, which would essentially unavoidable. Interesting to note, there's a white dot on the other side, suggesting she's probably got a cardiac source for her stroke. But yeah, so this was a case treated by Ken, and this is how we presented at our meetings. So each week we go through all the cases and we talk about the treatment metrics. And in this case, I think it was some venous access issues that made the time from the initial door to the CT a bit longer, which sort of bumped back the treatment time as well. And so basically, the message from this case is that these aren't always straightforward decisions. Oftentimes, patients are borderline, and it's ideal to have subspecialists making these tricky decisions. All of us who are on the TeleStroke service, stroke is our only patients that we see. And so in this case, it was really great in that she didn't require the procedure, and it definitely, in the cases where it takes a long time to get someone from Coffs to John Hunter, in the order of sort of 4 hours, having the ability to give thrombolysis and send them often is working out well. So we're getting a lot of patients that are opening up the vessel before they get there. Obviously, there's always process pieces to improve on, and we would have loved to have had her treated sooner because potentially we could have saved more brain. This is, as of May 13, this is the data of our treated or our seen cases. We've seen 745. We've taken over 1,000 phone calls, and we have reperfused 133. The bigger the circle on the map is the more cases that we've seen from that place. Obviously, Port Macquarie and Coffs Harbour are the largest because they were the two sites that kicked us off. And then, so to wrap up the remainder of my time, part of the brief was and beyond. And so, well, firstly, we've got a lot more sites to extend to. We're about halfway in our implementation at the moment. We've got 11 of 21 or 23 sites up and running. We have a lot of work to do to get all of those up and running. And then when they're up and running, there's a lot of sort of maintenance to make sure that these sites are running well, because we need to be called early. We need to get the patient through in a timely fashion, and as we sort of expand, the other things that are going to be really interesting will be things like taking on a research trial, which is a trial looking at tenecteplase, treating patients with tenecteplase. It's a multinational trial, and as a TeleStroke service, we're very well positioned to provide really important cases to some of these really practice changing trials, which can improve the way we care for patients beyond this year. And a big part of that is thought to be tenecteplase, which is a drug that has had some mixed literature, but we think it's quite promising. And treating some of these patients with large vessel occlusions with thrombolysis in very highly selected cases is where we think it's going. So basically, ignoring the time window, focusing on the metrics of the scan and the quality of the scan, and treating patient based on the image clock rather than the arbitrary time window clock. Another thing that's going to come about over the next few years, not straight away, is a stroke ambulance, which is predominantly going to be Metro, but this will come essentially on board as another sort of TeleStroke site. So when it comes up on board in probably a few years, we will be taking calls from a stroke ambulance with the same capabilities, same process, but trying to get patients treatment in the field, which will be a first for New South Wales. They've got one, building a second in Victoria, and there is some good data around the world to show that this has provide some benefit.
Oh, thank you. Thank you so much, Dr. Evans, for that presentation. And I was just sitting there thinking, for someone who's worked with stroke patients for 20, 30 years, and for people here who've had their strokes that length of time ago, it's just so wonderful, the work that you and your colleagues are doing in that acute phase of stroke, and how it's having benefits long term for people with stroke. So again, thank you very much for that significant work that you're doing. And thank you again for your presentation this morning and for your time. So if we can just thank Dr. Evans.